the journal scans, and some of the data interpretation and others. But in this third installment of the program, today we thought that we come up with a interesting and a more relevant topic, and which has been into highlight due to the present situation as well as certain current development that had happened. So today we would be discussing on end of life care and withdrawal of life sustaining therapies in ICU, and what are the current perspectives, what are the medical, ethical, and legal standing in our Indian practice situation. And for this, I would invite Professor Dr. Rahul Pandit, who is the chair of Reliance Group of Hospitals as well as the HN Reliance Foundation Hospital, who would be moderating the sessions. And I will request Dr. Pandit to invite our esteemed panelist, which comprises of one of the most eminent end of life care proponents. We have a legal expert, we have a palliative care medicine expert, and couple of practicing intensivists. So a very mix of a nice balanced mix of people who will give us the current perspective of it. So over to you, Dr. Pandit. And today we will only have this panel discussions.
Thank you very much, Dr. Kar. You've set the tone absolutely right. As I said in my post as well, one of the toughest processes in the ICU, one of the most sensitive processes in the ICU is end of life care. And it becomes even more difficult when you basically come to a situation where meaningful recovery is unlikely to happen, or death seems to be the only outcome which is likely to happen. And in that case, all of us, including the family, the treating doctors, paramedics, quite often think that life-sustaining therapy like ventilator, dialysis, inotropes, essentially pose an ethical dilemma to all of us. And we were struggling for so many years, though somebody like me, and I'm sure many of you who've practiced abroad, we've been practicing withdrawal of life-sustaining therapy for a long time. In India, because of various thought processes of individuals and quite forcefully expressed views, there has been, I would say, a very slow progress in this field. But now we are really poised at a juncture where we can actually gallop forward and do the right thing. So I've got very good panel today. I've got 5 extremely good panelists who are very, very senior and who basically talk about not just at the policy making level, but also at the ground level. So to introduce my panel, first I've got Dr. R.K. Mani, sir. Sir is a past president of Indian Society of Critical Care Medicine. He's currently the Director of Clinical Services at Yashoda Super Speciality Hospital, Kaushambi, Ghaziabad. And most importantly, he is the lead author for ICCM guidelines on the end-of-life care, palliation, and withdrawal of life-sustaining therapy. He is also one who spearheaded the legal proceedings from a societal point of view to help establish some sort of a law or some sort of a guideline, I would say, to go ahead with the life-sustaining therapy being withdrawn when futility was proven. Then we've got Ms. Dhwani Mehta, Mrs. Dhwani Mehta. Dhwani ji is a co-founder and lead at Health and Medical Law with the Center for Legal Policy. She is the legal head, and she is the one who can actually talk to us about the legal intricacies. She was closely involved in this case, which I was talking about, where the Honorable Supreme Court gave the judgment. So we've got a right person to take us through the process of how legally we are protected and where we stand. Then I've got 2 grassroots intensivists who work with the patients all the time. From 2 different cities of Maharashtra, we've got Dr. Sayi Prasad, a very senior intensive care specialist from Kolhapur. He's the director of critical care at Diamond Super Speciality Hospital, and he will bring us the perspective of what actually happens in the ground. And along with that, we've got a young and budding Dr. Shashank. He's also joined. Shashank, welcome. He's the secretary of Amravati branch of Indian Critical Care Medicine. Amravati branch, Mani sir, has just come into existence around 5-6 months ago. They had the installation ceremony just recently, and is also the director of Exxon Hospital, director of critical care at Exxon Hospital, Amravati. Now, this is the critical care team and the legal team. we've got a very, very important person, and I kept deliberately him as the last to introduce, and that's Dr. Mahesh Menon. He's a lead for palliation and pain at the Sir H.N. Reliance Foundation Hospital with us. And he's somebody who sort of brought in a much needed change in our hospital, in our thought processes, in the way he talks, in the way he leads it from the front. And it really makes a big difference to have Dr. Menon as a palliative care physician who actually is very, very, from the heart, is very, very firm believer that we should be doing the right thing when it comes to end of life care. So, with this introduction, welcome all. I would like to start off with the question straight away. There is no particular question that I've sent any of the panelists, just as a disclosure, so that we actually have. But the questions are not going to be anything. It's going to be basically pertaining to this topic, and all of you are experts in that. So, Mani sir, to start with you, can you give me a little? Can you sort of talk to us a little background about um, why this thought process of end of life care should be the center stage of ICU, just like we talk about sepsis as a center stage, ARDS as a center stage, how this is equally important, if not any less or more, and why such a large amount of work which has been done already in the work in the world, we have to sort of replicate some of it or even duplicate some of it. And I would like everybody to limit their question answers to around 3 to 4 minutes so that we can have approximately 15 questions in the hour. Mani sir, off to you, sir.
Uh, so you see, we must always grasp the context first, because very often this conversation drifts into areas which are quite tangential, not germane to the crux. Crux of the matter is, with advancing technology and interventions, and this fight till the end sort of a concept, we tend to overdo disproportionately, unmindful of what collateral harms we are doing in the process. And this is very common, as common as, a quarter of the patients in the ICU, that we do over too much, and particularly towards the end. It's not just about imminence of death. It's about stage and phase of illness, trajectory of illness. And in that context, we may be disproportionately doing more harm than good. So this is the context. And in this context, it is very sensible, pragmatic, appropriate, and compassionate to limit therapies. So while intensivists are always piling on more therapies and being aggressive about saving lives, at a point, and that transition we have to recognize as really good intensivists, we need to switch over to a different paradigm where we limit interventions and move over to a care mode from a cure mode. So this is the context. Now, why it has taken us so long is perhaps because we were a little out of phase with the rest of the world when we started critical care. We were more caught up with the romance of rescue, saving, whereas the West had crossed that initial fantasy, and then they came to the hard earth earlier than we did, and realized that there is a equally important, um, to recognize when the going is not good and the game is up, and we want to move over to a more appropriate, sort of caring. So, which is a more holistic care. What palliative care is? Palliative care is a shift of attitude, shift of focus. So, with the result that the quality of dying has become as important as quality of living, with the result that quality of overall care in terms of pain, suffering, which includes also psychological, spiritual suffering, and others forms of suffering, and psychosocial context, and patient rights, okay, individual rights of choice, all this come into play. So I'll stop because I've done my 3 minutes. So this is the background, this is the context in which we must let this conversation flow. Thank you, Rahul.
Thank you, sir. We will obviously come back to you again, sir, very shortly. Dhwani ji, I have a question next for you. If it's something which Mani sir just mentioned about patients' rights, and relating the Aruna Shanbagji case and the current Supreme Court judgment which came out on withdrawing life support therapy. Uh, where do you see the patient's right? Where they at the center of all of these judgments, both the judgments? If you could just dissect the two judgments out, the processes are obviously different, and Supreme Court made the second process much easier. But what was the difference between Aruna Shanbag and the current judgment which came through, and why do you think this is important? This the current judgment.
Sure, that's a really good question, and I haven't thought about it in this way. So, yeah, just give me a moment to try and collect my thoughts. With Aruna Shanbag, I would say that patient dignity was at the heart of the petition. So, the person who filed that petition on behalf of, or as the next friend of Aruna Shanbag, was obviously concerned with dignity, and of course, not just the dignity of that particular patient, but generally the dignity of patients who are in that kind of situation. And while the court, I think, recognized that and understood that the right to life includes the right to die with dignity, um, in some sense, the patient herself in that case was not at the heart of the matter, because ultimately the court gave weight to the opinions of and the sentiments of her caregivers, which was the nursing staff at KEM hospital. So that actually played a very important role in determining, I mean, in the court's judgment in that particular case. The court laid down a general principle that you can withdraw life-sustaining treatment from a person who has lost decision-making capacity. And it said that if every time you want to do that, you have to go to the High Court, which will act as the guardian in some sense of the patient and decide whether it is suitable in that case to withdraw life support. So that was the context for Aruna Shanbag. With Common Cause, which is the judgment in 2018 and 2023, the patient, and this is interesting because here there was no specific case that was brought before court. It was a petition filed in the public interest by Common Cause, and then later in 2023, there was an intervention by the ISCCM itself. But the court was discussing these questions in the abstract. It didn't have a particular case to apply its mind to. So paradoxically, that was where patient autonomy became very much the heart of the case. And the court was able to lay down these lofty principles in the abstract. And there, again, autonomy, dignity, privacy all played an important role. But I would say that the patient really became the center because advanced medical directives were recognized as legally valid documents. So you recognized that a person had the ability to exercise autonomy even after they lost their decision-making capacity in some sense. As in, well, of course, they would have made that advanced directive when they had decision-making capacity, but it should extend to a fact situation when that decision-making capacity had been lost. So in that sense, I would say that again, the patient was put at perhaps at a slightly, I mean, the patient became more the center of the 2018 and 2023 judgments. But even then, as you can see, this is still not the full-blown idea of autonomy at all costs. Because if we, and I'm sure we'll talk about the procedure in more detail later on in the webinar, the procedure for withholding and withdrawal, both where you have an advanced medical directive and where you don't, still requires medical opinion to weigh in on whether withholding or withdrawal is beneficial or not. So it is patient autonomy balanced in some sense by medical opinion. Maybe the court saw that as a kind of safeguard to prevent patient autonomy from being taken over by extraneous factors. But I would say that while we're moving towards a patient-centric approach, there are still many countervailing factors, many other considerations that are still part of our jurisprudence.
I'll come to that things and the process very shortly. I'm going to get Dr. Menon in next. Dr. Menon, you have come as a palliative care physician. You have trained yourself as an anesthetist and a palliative care physician and a pain specialist. Where do you see we are standing? Are we anywhere near actually offering proper palliative care as the Western world does, and how a human being desires to be treated in the end of their life, not just dying, as rightly put by Mani sir. It's not about just dying, but it's about your individual rights and dignity. So some thoughts from you. Then I'm going to come to Mani sir for him to explain the process of the 2033 judgment, and then I'm going to come to our Dr. Shashank and Dr. Sayi to understand where as an intensivist you feel. So Dr. Menon, first to you.
Hi. So first of all, thank you for this opportunity to be on this platform with all of you so I can talk. I always declare one conflict of interest in these talks, that I am mortal. So that's the first conflict of interest to declare. So this is going to uh, involve only those people who are mortal. So we can just discuss this further. Uh, the reality is a little different on the ground, because one of the stumbling blocks that I see as a palliative medicine physician is the referral patterns to palliative care, or the involvement of palliative care is at a stage when the family is not in a position to make a lot of important judgments regarding the care of their loved ones. And this is one of the observations. The second observation on the ground is that to experience good quality of life, people must seem to experience bad quality of life. Then they start asking for palliative care. It is never assumed that we can go from good quality of life to good quality of life as a continuum. It is good quality of life, lot of suffering. Oh, where is palliative care? And then we come in. So the challenge is in this format. The third problem is in terms of the dying process itself. So it is not dependent just on physicians. We may have the most brilliant intensivists, the most brilliant specialists, but at the ground level, what happens is there's a huge obstruction from the nursing staff, because there's a lot of fear of repercussions, because they are going to be at the scene when events happen. So to bring the nursing team on board. And then the last part is a policy, which is supposed to be from an organizational level, whether the organization has support for these particular thought processes. And these principles don't apply just to one organization. Wherever I've worked, even in Singapore, in Bahrain, most places in India, the same principles apply. Because ultimately, death, we look at it as a medical process, but death is actually a social process. And we just reflect what is happening in society. The mistrust, the confidence, the maturity, it's all a reflection of the society and the times that we live in. So I think it's a great initiative to bring this out and talk about it and evolve into a great medical event. So this is my experience, and I'm sharing.
At least the beginning, Dr. Menon, is what I would say. And I'm sure, as Professor Mani said, that we need more of your clan to grow. So Mani sir, I would be coming straight to you to explain the audience here what actually the judgment is and what it meant. And if you could just give us a little understanding of the process involved, so that we can start asking our ground intensivist, our backbone of the country, of the ICCM, that what they feel about it and how they take it forward. Mani sir.
Dear friends, at the outset, I want to say that we have over legalized this decision making. Actually, legal side is only one leg of a three-legged stool. Okay, it combines the medical skills, the knowledge of and integration of ethics, and additionally, the law. What is happening is there was an overemphasis of where is the law relating to withdrawal and withholding in the minds of physicians in all the 25 years that we have been at it, okay, in trying to improve end of life care in the country. I'll confine myself to law because that's a question now. See, the legal evolution dates back to 2006 when we first had the draft bill, 196 draft bill on how to treat the terminally ill patients. There they separated all this withdrawal, withholding from euthanasia. So that was one movement forward. It's neither anything to do with euthanasia nor anything to do with suicide laws. That was very clear. But they didn't believe that advanced medical directive could work in India. It is subject to misuse. So the draft bill disallowed advanced medical directives being legalized in India. That was one stumbling block. In 2012, with Aruna Schonborg, we got in principle, the acceptance of so-called passive euthanasia, an unfortunate term. What they meant was withdrawal, withholding of life-supporting treatments. That was in principle, in theory, allowed. In that particular case, it wasn't operationalized because the next friends didn't want it for sentimental reasons. So they didn't explore the patient perspective, what the patient is experiencing, the patient's suffering. In that judgment, they hadn't explored that. They only looked at it from the right to live and right to die in dignity perspective. Cut to 2018, we had for the first time, as Dhwani said, a law which allowed the treatment refusal by virtue of autonomy and privacy, and thereby withdrawal withholding was allowed, and it was allowed also when you lost consciousness through the agency of surrogates and the physicians. However, what was gained in principle and philosophy, we lost in the procedure, because they advised a three-tier procedure involving the district collector and also the judicial magistrate. So obviously the bureaucracy and the judiciary was coming into play by the bedside, so that was not acceptable. So our appeal was accepted, and in 2023 we had a simplified form. Now what we have is it only involves physicians. There are no bureaucrats, there are no judicial officers. So that was a big gain, but unfortunately, it is not as simple as it is usually the practice in the rest of the world where EOLC is well developed. We have a two-tier process, and the catch is that the primary medical board is simple enough. You know, the physicians involved primarily in the care of the patient in a critical care unit, you have 3 or more physicians of 5 years or more standing. So that is easy to put together. But the secondary medical board, which is a must to oversee, according to the Supreme Court, one of these physicians should be an appointee by the CMO. So here's the crux. Then people ask how to get an appointee from the CMO. The CMOs had not been sort of informed of the court-prescribed procedure until now, but now the process is on. The process is on. Now information has gone from the Supreme Court to the state high courts, and from state high courts to the secretaries of the state ministries, and from thence to all the districts. So this process will be put together, wherein the CMOs of every district will be informed of this court procedure, and we'll be able to access the CMOs of our districts to appoint these physicians who can who can play a part in the secondary medical board. I want to hasten to add here, all the 6 physicians can be from the same hospital. It is not necessary to invite people from outside. The secondary board can be a standing committee. You can have multiple physicians appointed by the CMO, even in the same hospital, so that this process can be expedited. So there we are. I said my piece in brief. Okay, it may need more explanation, but this is in a nutshell.
Thank you very much, sir. I think you've actually explained the context as well as the current judgment quite well. Now, Dr. Sayi, you work in Kolhapur, which is a fairly big city, big town, though it's not the big smoke like Mumbai or Delhi or Chennai, but it's a big town with a large population, almost a metropolis city, more than 10 lakh people live in there. What do you think is happening at the ground, Dr. Sayi? Are people even aware of this judgment? Is there even a talk amongst the critical care specialists and physicians about this? And if yes, do you think you'll be able to implement this?
Yeah, right. So this is an interesting question, but the fact is that still most people are not aware of the recent judgment by the Supreme Court. So at base level, people still think that either you should have a brain death certification, or the patient has to go against medical advice, and they'll not be able to at least foregoing life-sustaining treatment is not an option in the hospital. But at least in the intensivist circles, we know and we keep discussing. But how to implement it is a very difficult thing, because basically what has happened as intensivists, we have been trying to be aggressive in saving people till the end. So we go, say, even if it is 1 or 2%, we say we'll try our best. And we tend to give in to the aspirations or expectations of the relatives. So even if you would give them 2, 3, 5% of chances, though, they still say you try your best. So these kind of situations, and then at the same time, it's on the part of the relatives. They also don't want to feel guilty at some level that they have fallen short of in giving their who are the loved ones the best treatment till the end. So these are some of the important things which we face at the ground level. But apart from that, very important thing from our side is we still feel a moral issue. If you say, even if you say it is a futility of treatment, we know it could still be 2%, 5%, whatever the chance. So here you jeopardize that small, whatever the chance patient could have had in the back of your mind. At the same time, relatives also will have the same kind of situation. But maybe over a period of time, we overcome this and then probably start accepting that we are doing more harm to the patient as well as the relatives by continuing this kind of life-sustaining treatment overall, where we know that it's definitely going to be futile.
So I'm not going to give my opinions because I want panel to express the opinions. I'm going to keep myself to the job of a just person asking questions. Anybody who has questions can put them in the chat box as well. We will take those questions at the end of 10 minutes, last 10 minutes of the webinar. Dr. Shashank, you are there?
Yes, sir.
So Shashank, what do you think is happening in Amravati and Nagpur? Do you think this judgment is being made aware in the medical community? Do you think this is something which is well received and it could be taken forward?
No, sir, I don't think at the grounded level, this decision has taken well at this grounded level, because people are not aware about this end of life care things. We need to understand the colleague also and also the relative what is actually the end of life care. What is actually when we in my practice only, when I explain the poor prognosis of the patient, and when I know that there is no not justified to continue treatment, or when we discuss the withdrawal or withholding the treatment, they actually the patient didn't received very well, and they actually take the patient lama or dama. The main part in grounded this two diversity is actually they spend money in expecting that good outcome, and when we actually before end of life care, when we actually talk them about the poor prognosis, at that time most of the patient or relatives, they either choose to go lama to some government hospital or a charitable hospital in view of their financial constraint, or some they want to shift to the some higher center when if they have finance ready. So it's very difficult. But some kind of patient like a terminally ill cancer patient, I do discuss with them. I do discuss. I do take the multidisciplinary meeting. I do involve the primary physician, sometimes oncologist, and make them understand the terminal illness. So most of the CA patient, they do understand the thing, and they allowed us to do the things or end of life care. What we do, pain control, comfortable life, these kind of things they allow us to do. And we do proper consent for that. It's very difficult for them to just make them understand these things.
I hear you, and that's unfortunately the reality right now. And that's what these webinars are for, changing it. Coming to you, Dr. Menon, and then I would come to to Dhwani ji as well. Dr. Menon, are we so somebody said just now, I think Shashank or Dr. Sayi, that we may take away that 2% chance. Is it really about chance, or we as critical care specialists always are towards the extreme? Okay, so I must have said in my conversation about a possibility of recovery and not, and forget about the percentile for 2%, 5%, 10%. But do we actually wait for that for palliation to happen, or somebody who is terminally ill, or who is going through an ICU admission as well with no foreseeable meaningful outcome? For example, let's say a very bad head injury who is now past the first 2 weeks and it looks like the prognosis is going to be poor, or a terminally ill malignant patient, or a patient who is in early chemotherapy. So what is it that you want to sort of say to this patient, that you're taking away their chance, or you are just changing gear from curative intent to a more supportive intent?
I totally get your question. So the trajectory of diseases in the ICU is a little more, is a little different from that in the ward, because you can leave the ICU either after you leave the planet, or you can go to the ward and go home. So there are only two ways out of the ICU. Now, when the person who is unwell, they may have an acute exacerbation of their health condition that leads them to the critical care unit, where they have to be supported. This is a slightly gray zone, because this is where the challenge is, that huge trajectory of how suddenly things have happened. It may not give people enough time to practice, prepare, or even predict or prognosticate. But there are clear prognostic indicators for people with neurological illnesses, with malignancies, with multiple geriatric complaints, where we can actually decide, at least not about chances or choices, but giving them an opportunity to think how they would like to spend a critical period or a valuable period of their life. If we medicalize this event of their life by not giving them a choice and offering them a choice only when they are not in a capacity to do so, or on a ventilator, and then talk about probabilities and chances, it's very difficult. Sometimes it has been easy for the families when we have asked the question to the relatives, what would you like? And they say, I don't want to have a tube placed down my throat, etc. And they are very clear about that. As I said, because they have experienced some form of suffering in another family member, or they have gone through that period. So they say they are very clear about their personal choices. The question here is, are we giving our patients enough time to arrive at that decision? Are we giving them the choices, or are we forcing ourselves into a corner by not talking about it? So are we like, and it's not critical care alone, by the way, because critical care, unfortunately, I find suffers from the same challenge that palliative care also finds, because it's multiple specialists. So you have to deal with a complication of one organ where the specialist is, look, the kidneys are working fine, but the patient is critical. So if we look at people in piecemeal approaches, we'll never see that concept of personhood. And it's all about giving that person that personhood, that dignity, and that control over their quality of life. And this is challenging, because quality of life is not measurable on a blood test or on a scan. So I think it's more of heuristics and more of using common what would a good family physician do? It's coming to that part. So I hope I'm able to answer what you asked.
Well, I think so. It's not a very easy question to answer. I mean, it's not even an easy question to form, because it's not about giving away the chance. You're actually telling them that you still have a chance, but the chance is of a reasonable quality of life towards the end of whatever days or years you've left, or weeks you may have been left with. Manish sir, I know you answered the question on the chat, but I would like to still, I would like you to still speak about it. Two questions. What if the family members don't agree to it, or is there a split decision to it? And then the question asked by Mr. Sashi, Dr. Sashi, is do we need to approach the judicial magistrate? So I think both these questions are very relevant and they need to be just clarified.
I think we must firstly understand that we are only giving an opportunity for the family to exercise their rights. It is not anything, we are not enforcing anything, you understand? We are having a chat. We are firstly sharing our reflective view of what the prognosis is. As we all know, prognosis is not a mathematical formula. It is not a mathematical number. And just because you say 2 or 3% chance doesn't mean, 2 or 3% chance has to be held on to. Not necessarily. If the patient chooses, if the family chooses that that's not worth it, they must have the opportunity to look at that. And you also have a duty of care of beneficence and non-maleficence. Our duty of care is not just to save and at all points try and save. That is not, that's a very, that even Hippocrates didn't believe. Even Hippocrates said, if you're overmastered by disease, you just stop. Okay, do something else, do care in a different way. So this we find every day. I don't know why we have to see in a binary fashion. Judgment we are exercising, clinical judgment we are exercising at every point, and we are not mathematicians or engineers, we just have a specific way of doing things. We have to combine many things. Even our evidence-based medicine has to take into consideration the patient choices. So if you think you can exclude subjectivity totally from medicine, we are not practicing medicine then. We're practicing something else. So let us understand deeply what we mean by a physician and a caregiver. It means we provide an opportunity for the patient and the family to understand the realistic chances. It's not 0 versus 100. Realistic chances. See, poor prognosis is a bad word. You give prognosis, okay? Give them what the facts are. See, I have not had great deal of difficulty in having different family members saying different things, because they do say different things, but you have to communicate and reconcile. That is the art. Communication is central to this whole thing. This is not one-off event when you rattle out the prognosis and then you just take a decision. Not at all. You may have to work at it. By and large, you drive a consensus. You may not be able to drive a consensus in 10 out of 10 cases. If you drive a consensus in 6 out of 7 out of 10 cases, it's fine. There's no situation in medicine when you can get 10 on 10, The issue is wherever possible, you drive a consensus. And if that is possible, then you implement. Where there are serious, discordance, either within the family or between the family and the physician group, then don't jump to the conclusion. Wait. Go back to communication again. See if you can take smaller decisions, work at decisions. You can maybe take one DNAR decision. Okay? Then you may work at a non-escalation decision. Then finally, if required, then you may take a withdrawal decision. So all these options, this whole range of things are available to us. Let us cultivate the art mixed with science, wholesomeness of medicine. Right. And palliative care doesn't begin and end with end-of-life care at all. It begins at the point the patient enters the ICU, from the ICU physician point of view. But the component of palliative care increases. And as we reach end-of-life care, it may be totally palliative care. But then there is a progression of the proportion between palliative care and aggressive care. So we experience this every day. So let us reflect on it and process this, okay, and crunch it into a practice. And this is quite possible. We should not be holding on to prefix notions. No, it may be difficult to drive a consensus with the family. It isn't. A lot of the families are thinking like us. We must give them a chance, an opportunity to communicate their feelings. Okay, that's what I would say, Rahul. Yeah.
So I think, well said, sir. I don't think consensus can be there, but generally we take an assent of the family and move ahead. And Arindam posed an interesting question. We might take it at the end. Dr. Sayi, I'll come back to you. I know you've sort of raised your hand. I want to speak with Dhwani ji first. There was an interesting question, and I always wanted to ask this question as well. And I know Mani sir's answer on this. What's the legal status of DNR, Lama or Dama, whatever you call it? And is there any provision for if you don't do CPR, you're going to be in a problem? Legally, I'm talking about. Medically, ethically, we know a lot of things, but legally.
Yeah. So the way I see it is that DNR or do not intubate are all basically decisions to withhold treatment. And now that the Supreme Court has said that that kind of withholding is legally permissible, in the same way, DNI, DNAR is also permissible. The only question then is, what is the process that you follow for this? And I would say that it's the same kind of process. Now, then this is where we can have more of a debate whether it is something that will practically make sense and can be actually implemented in a real life critical care setting, which is that whether, before you take a DNR decision or a do not intubate decision, you go through the same process of constituting two boards and obtaining the consent of the family members. I mean, so theoretically, yes, because there isn't anything to distinguish this kind of situation from any other form of withholding treatment. So that is but practically, is that something, you as the medical fraternity think is implementable? That I would love to hear from. But yeah, as in, is it legally permissible to have a DNAR decision in place? I would say the unequivocal answer to that is yes.
Okay. Sayi, you want to have a question? Then, I think we go back to Dr.
Yes,
Mani and
the
other.
one of the basic issues we face at ground level is that you have decided, you have communicated to the people. There is a primary board, secondary board, and you have taken a decision. So our concern here is that whether the person next of the kin or the surrogate whom you are talking to and who is giving consent, is he the right person? So sometimes that may be wrong. The second question is, in spite of following all these things, if another person who is not there and he comes from abroad and then later he questions the validity or the intention of your decisions, then do we have legal immunity and are we the part of the whole process, and do we need to process the legal, face the legal consequences?
So who wants to answer that question from the panel? It's an open question. Anybody can answer it. I know the answer, but as I said, I'm not going to be giving my opinions. Mani sir, Dhwani, or Mahesh, anybody?
Rahul, I would like to answer that. This has been repeated ad nauseum that somebody may come later on. In 25 years of practicing end of life care, I have very rarely found this. You can only work with the people you have around you. The same questions may arise if you take an aggressive treatment option. Somebody may come later on and say, why did you do this? Particularly if it doesn't end well. So I don't know why we are splitting this. If you take an option to operate, okay, in a terminal, last legs patient, and it doesn't work, somebody may turn up and then say, oh, you did surgery because you want to make money. And who gave you the permission? My brother? No, I differ from him. I would not have allowed this. So the same thing can occur. We have to use our senses as physicians. Now, if you discern that there is a controversy in the family, you wait, talk to them. You say, is there anybody else important I need to talk? Nowadays, you can talk over the phone, you can talk over video, you can talk over Zoom. See, these objections I have listened to for the last 25 years, and in my own practice, I don't find it. And I'm practicing this every day. Every day I'm walking into an ICU. I do talk to as many family members as possible. I do try and engage with all the important members of the family. Sometimes I insist that the wife be there or husband be there, even if they're emotionally very distraught. I say, no, I'll speak with them. Okay, these are the precautions you can take. But you can't say anybody will turn up, later on and hold you to court. See, you can be held to court for anything.
Yeah.
Now we are not doing much withdrawal and withholding. In this country, we are doing Lama Dama, and even a Lama case has been held to court, 10 crore suit. So what I'm saying is, immunity from legal suits.
Yeah.
But if you have functioned honestly with professional integrity, then you can protect yourself. That is all in your hands. You can't prevent all people, anybody from wondering about what you're doing and filing a suit. So as physician, we should work honestly, not fearfully.
Yeah, I think legal next of kin is also identified nowadays in most hospitals very clearly. And you can only work with people who are around you, and you can always make an effort to do a phone call. I think that's very well
Yeah,
very
and just
said.
one thing to add to that is that where there is an advance directive, there someone will have nominated their decision maker. So then becomes easier for you as the treating doctor to identify who you should be consulting and whose consent you should be taking.
Okay, I'm going to ask a question to Dr. Menon and then come back to you, Dhwani ji. And maybe Shashank can add to it. Dr. Menon, here we are talking about doctors and medical people understanding that the prognosis is poor. And the prognosis may be poor, and let's say my ICU did not approach for end of life care. But the moment you came in as a consultant, they said that we would like to withdraw ventilator. Uh, how do you take this with your colleagues, intensivists, physicians, surgeons, whoever are involved? And do you think that if it is not offered to the patient, we would actually be legally liable that we did not offer a process which was already been established by the court, and we refused to accept that process?
I wish we all feared the law so much, to involve palliative care early. However, the challenge is for a lot of colleagues who are in critical care to talk about palliative care when we don't have enough palliative care professionals. So if you're talking about withdrawal of someone, for example, a person with a lung disease who's having a lot of difficulty breathing and they go on to a ventilator, all right, you remove them. Let us go to a hypothetical situation where you remove them. How are you going to take care of them in the ward when they are out of sight? How is care being provided to them? How is the last phase of their life being taken care of? That also falls upon people who are specialized in dealing with dying patients. And that could, I'm not saying that palliative care physicians are the experts in it. What I mean to say is that there has to be some amount of training in dealing with what happens after de-escalation. We have to think beyond the point of having withdrawn life support. After having withdrawn it, what are the steps that we would follow? So care of the dying patient itself has to be taught before we go on to the de-escalation part. This is the first part. The second part is, are we more than happy? I think it should be incumbent upon, like Dr. Mani mentioned, to integrate palliative services with intensive care at a very early stage so that conversations can be had and de-escalation can be had. Setting up a board is our moral responsibility now that we have directions. And I just wanted to answer that with a bit of a question that we have the Ministry of Health and Family Welfare, which has put up a proposal recently, which talks about the primary board, the secondary board, and probably a hospital oversight committee that looks at audit of all these activities. So if all of that is in place, it'll be streamlined for palliative care to work with critical care when the choice is offered, when that choice is taken. So we have all these options available for people with advanced diseases. Dr. Rahul.
Yeah, I think that's good. That's something which you were said. Now, I always feel, and I agree with what Mani sir said before, that we've over legalized it. I think the ICCM guidelines should have been taken up by the professional body guidelines. Palliative Care Society came out with the same guidelines, and we should have just implemented that. I firmly have a fear that since the judgment has come out almost a year ago, more than a year ago now, year and a half almost, we've not had a single case which I know has been documented to follow this process. There have been a number of cases where withdrawals have done, I know that, but not a single case which has documented this process. Are we still looking at the same kind of a limbo where we had with Aruna Shanbag case? Because there is this complex process of two people and two committees and six doctors and stuff. Or we are going to look at it positively and say that there are six doctors, so there is a good immunity, the patient gets good immunity, legal immunity, the patient gets a good clinical opinion from six different physicians. The hospitals have a good backup because it's backed by the law, as well as there are six doctors involved, one independent or one nominated by the CM or whatever. I'm still confused. Honestly, I know my views and I'm a very proponent of this process, but I'm still confused at why we've not been able to implement this process. So Dhwani ji, you and then Mani sir, and then Shashank, if you have, or Sayi, if you have anything to add, please.
I mean, I think the stumbling block has been the secondary medical board, which requires the district chief medical officer to nominate someone. Now, why that is happening, I know the answer at one end, which is that state governments need to pass orders to direct chief medical officers to do this. It's not as if the chief medical officers all know about this Supreme Court judgment and can, magically set up a procedure like that. So the responsibility really is of the state governments. State governments have been passing the buck on by saying that they haven't received intimation of this from the High Court registries, which are supposed to forward this judgment to them. See, all of this is just, the kind of bureaucratic passing the buck. Now, after the Union Health Ministry has released these guidelines, there should be no excuse for state governments not to act. These guidelines also contain draft orders that state governments can pass, which lay down a clear process for how district CMOs should be empaneling people. So if this still doesn't happen, then I think then the onus really is on the medical community to go, to either one, like Dr. Nikhil Datar has already filed a petition asking for custodians to be appointed. Same way we have to direct now the court then to say that CMOs should be empaneling and nominating doctors to secondary medical boards. Someone should take an actual case to court and say, look, we couldn't act in this situation. This person had to suffer. Treatment couldn't be withdrawn as per their wishes because you didn't set up that mechanism. So, there are two. I am actually personally not in favor of going to court again and again. We have already had a lot of complication and confusion from the court. Anyway, I'll come to the other case that we are going to court for a little later. But in this kind of situation, I think, see, everyone has, especially associations like ISCCM, IMA, etc., have good channels of communication with the relevant people in state governments. So the way to do this is to continue to impress them of the urgency of this. And I know you've done this, Dr. Pandit. We've been together to a meeting where we have tried to explain what the urgency of this is. Everyone always wants someone on top to tell them what to do. Now, it was the Supreme Court. Now it has to be their most immediate superior. So we really need the relevant authority in the state health department to be able to do that.
Yeah, but it's a shame, Dhwani ji,
Now,
that
Rahul,
yes, sir.
I am very hopeful. Dhwani is very determined, and we are all those people who are passionate about improving the quality of intensive care. We are all determined. Now, the thing is, it must come from us. As Dhwani says, we can't be told all the time. Now, what I prioritize ethical practice. Okay, I prioritize advocating for patients and doing justice by them. If the structure on the ground is not helping, then we have to make do with what we have. I'll tell you, for instance, I'm taking these decisions. I'm not waiting on all these processes to be there. So whatever I can implement, I implement. In our ICU, these decisions are signed off by 6 physicians. We don't have a CMO empaneled physician because the CMO doesn't know. But that doesn't mean my patient can wait. I'm taking it. I'm taking the decisions every day. I don't feel constrained. I'm able to put together easily 6 physicians. Because willy-nilly, so many physicians are involved in the patient care in the ICU anyway. And our communication is systematic. We communicate with every family member every day in a systematic manner. And that is also done with multidisciplinary team. And this has become the norm. What I mean to say, 2 or 3 or 4 family members are talked to, we discuss prognosis, whatever we have written in our guidelines. I'm telling you, touching my heart, we are following as far as is possible. Absolutely. If I don't have a CMO appointee, I can't have that CMO. So we have to put pressure on the government collectively to say we want to practice ethically. We want to do justice by the patient. We want to listen to patients' choices and honor the choices. It is not us asking the patient to do something. On the contrary, we are listening to what the patient wants and honoring what the patient wants. And do you not want us to honor patient's choice? Do we have to be stuck up like this because there is one provision which you can't follow and you yourself have not followed the Supreme Court orders? So that is the way we have to argue our case passionately. I don't know why we are all the time slavishly waiting for courts to tell us. When we have got the patients to care for every day. How are we caring? If we don't have these provisions, if we can't integrate ethics and practice ethics, then how are we caring? We have to ask ourselves this question. Rahul, I'm sure you're not caring without ethics. It's not possible.
Yeah,
You
it's
wouldn't be in your position if you couldn't care ethically
100%.
and with professional integrity. Now,
Absolutely.
this is what I mean. If we have to be true to our profession, we have got to be a little, we have to push our case more forcefully. And if we don't practice, no court is going to, try and mitigate, this process. If we are practicing and we collectively say this is too onerous, we must simplify further. Because actually, we had asked, Dhwani is Vidhi and doctor's representation from ISCC. We said we don't need only one step, as is everywhere else. Everywhere is only 2 physicians. Okay, if you want to have 3, it's fine. If you want to have 4, it's fine, but not 2 steps. But the government of India, the Ministry of Health had a different point of view. They said we'll stick to the 2018 judgment. So we had to come somewhere in between, where we wanted to not be in the throes of the bureaucracy and the judiciary. We wanted the physicians to work together with families and then take a decision as is done around them. So this is what we have got. We have got to work with it. I must tell you one example. When the Transplantation of Human Organs Act came, it was 1994. We were doing transplantation since 1982.
Yes.
And before the process was in place, it was 1999. But between 1994 and 1999, organ transplantations were taking place.
Yes.
But after 1999, it just took off. Now, in the last decade, it just took off because the process had gelled. We had become good at it. We all our initial shyness or initial ambiguities vanished. We improved on the rules also in 2014. So this is what will happen here. For that, the physician must tell himself, I must practice ethically. Okay,
Absolutely.
I must not make excuses. I must not hide behind, the legal minutiae.
Yeah. So agreed, sir, completely. And sometimes I feel that we should actually file a petition in the court that if a professional body comes out with the guideline, it should not have any other impedance in terms of process has been questioned or the consensus has been questioned, because the professional body is acting within their specialty to talk about it. So with this, sir, I would like to take some audience questions, and we would open it for around 5 audiences to talk about. I'm going to answer one question because it's about organ donation. DAT is asking that, can I withdraw ventilator if the patient's family says no for organ donation in a brain dead patient? So if you're dead enough to donate, you are dead enough to disconnect. Let's just put it that way. You have absolutely nothing to fear for. You can go ahead and disconnect the ventilator. Absolutely. So anybody who wants to have questions, they can actually raise their hands up. 5 questions I'll be happy to take. We'll extend this for another 5 minutes, for 5 or 6 minutes. Any other questions? Arindam, you have any questions?
Yes, sir. But we being the host, I would see that if any other people first put a
Yeah, so
question.
we'll wait for a minute if somebody wants to ask a question.
Uh-huh.
Lot of them have been answered by Mani sir and Dhwani on the chat box.
But if not, then I would ask 2 questions very quickly. One is that Dr. Menon put up a very nice say. My question to all of you, particularly Dr. Menon, when do you think is the best or ideal time to involve a palliative care person? Because it's tricky, right? If I involve you early, then it sounds or it indicates that maybe I'm little acting like a naysayer or a negativity on that part. And if it is late, then it gets difficult for you also to wait. So what do you think is the best time to get a palliative care person in?
So thank you for asking this question. So I do understand totally clinically in a real world scenario when you are dealing with the person and you've been handed this complex case with multiple specialists involved in it. I believe sometimes it's not the appropriate moment because you're giving mixed signals to the family. Here is, we are going all out to get this person better. And here is also palliative care who deals with dying people. So it's a very confusing signal because we can see black and white and a lot of gray in between, but families may not be able to see it. So we understand that. The point is that as doctors, we are able to see the disease unfold in front of our eyes. So the moment we feel that the prognosis is not as expected, or the outcomes are not going to be favorable for that particular case, in that particular situation, it's better to involve supportive care measures so that we can start introducing ourselves. This happens in a small set of people. In a lot of people, the same problem that we face as palliative care physicians is faced by critical care specialists, of course, is that you don't have prior contact with this particular patient before they come to the ICU. So I think rather than asking when the critical care teams should involve palliative care, I think it's about the other specialities who have people with chronic illnesses should actually integrate some bit of palliative care into their work from the beginning so that they are primed when they come into the ICU and they know that this outcome is possible. So for the acute scenarios, I understand it's a tricky judgment. It's totally your call. But for the chronic exposures, I think it's better to involve palliative from an early phase. Especially in malignancies, we do it often because in India, it has evolved through the context of malignancies. But in non-oncological conditions, we face these challenges too.
Motor neuron disease, some of them which are
Yes,
very
yes.
clear, I think you should be having a palliative care physician involved early.
Early.
Arindam, you had another question? Somebody else has a
Yes.
question? Please raise up a hand.
Till that time, Miss Dhwani Mehta, you clearly wrote somewhere in the chat box that
Yeah.
the withdrawal process and organ donation has been delinked.
Yeah.
Can you please clarify on that part? What if someone has a withdrawal process initiated and
Yeah.
then unfortunately proceeds towards a brain death? Can't we consider that person for an organ donation? What do you mean by delinked? Yeah, a
No,
person who is
yeah,
undergoing a
by
withdrawal
delinked,
process.
sorry, but I should clarify. By delinked, I meant that a person is brain dead irrespective of whether they have consented to organ donation or not. They can't be brain dead for the purposes of organ donation, but I mean, they can't be brain dead if they consent to organ donation and not brain dead if they don't consent. So, if a person is brain dead, then the logical consequence is that withdrawal can happen. So, withdrawal can happen irrespective of whether someone has consented to organ donation or not. And it can happen prior also, as in you may decide in a particular case that you want to initiate withdrawal. That may happen. Then after that, the person may be brain dead. Then after that, of course, consent for organ donation can separately be obtained as well.
And lastly, Manisha, do we need a consensus amongst the family members for withdrawal of support? What if there is a
Withdrawal of support in brain death?
No,
Withdrawal of
in
support in
withdrawal
brain
of
death
support.
or outside of it?
Withdrawal of support. For
Withdrawal
example,
support, of course, you need consensus. That is what our pathway says, and that's what the Supreme Court says. It doesn't say you take a decision unilaterally. Let's understand the principles. Doctors can't take these decisions unilaterally.
No, I'm not talking about doctors, sir. I'm giving a hypothetical situation. 3 family members, 2 sons, 1 daughter, and others.
No, that's what I'm saying.
And
But
most
there
of
are,
the time,
while such family conflicts do occur, but there are multiple times when there is no conflict or there is a conflict we are able to resolve. Once you resolve and there is consensus, then you go ahead. And these are very common. It's not difficult.
So the clear message is that we have to come to a consensus before accepting the decision of withdrawal.
Exactly.
So
you
no
don't
two
force. These are shared decision making means what? It means just this. And the Supreme Court says the same thing. They don't use the word shared, but they say you cogitate with the family. That is in the common parlance, different language. You cogitate. That's what it means. We sit nice and then we chat and we discuss, we cogitate, and then you sign on it. There's your document. So is it hard to understand? We must, in fact, evolve a good consensus process within the treating team also. In fact, the whole medical practice can lift itself up if there is enough cogitation within the team also, so that you make less mistakes, that there is a teamwork visible, and that is more reassuring to the families also, that there is a teamwork visible. Otherwise, there are different voices heard. Neurologist comes and says something. Neurologist says, even if the person is dead, Sometimes they say prognosis is poor. So which gives a different idea to the family. So the words that we use are very important. If somebody is dead, there is no prognosis. It can only be dead. So we have to use the right words. Sometimes we use words also without grasping how it impacts the family. So we must therefore speak in one voice. We must have all the specialists concerned with the patient talking things over, finding one consensus, even if it takes time. If the consensus process doesn't happen immediately, you must meet again next day. And in the light of new reports, new condition of the patient, you may come to an understanding. Then you present that to the family. This is what our pathway says, incidentally. If you see the figure 1 of the ISCCM IAPC guidelines, now we have articulated these in these words and then expanded on them in the text. How exactly we do. So this is not, we are not talking theory. We are talking exactly what happens on the ground and how it can be done. Right. And this, if we do this, if we practice this, perhaps things will get easier and easier, and our practice also lifts itself up to a more to a more caring, patient-centric and family-centric affair.
Thank you, everyone. So I'm just going to summarize. So the questions were that end-of-life care and withdrawal of life-sustaining therapy. What is the current perspective? The current perspective is that there is a ethical need and absolute consent to do it ethically. There is a medical need and a medical consent to do it, and there is a legal consent to do it in form of the provisions given by the Honorable Supreme Court of India. So we need not worry about it. We need to just set the processes on the ground, take some thought processes from this webinar. Like Manish sir said that he still does it with 6 physicians around and doesn't wait for the CMO to appoint it, which I think is the right way to go across and do it. And involve your palliative care physicians first. At the ground level, I think we need to spread the message that such a process exists and there is something which is available for people to utilize for every citizen of this country. And I see it in this way that it's a right of a citizen. If the Supreme Court has given a judgment, it is applicable to every citizen. It's not just applicable to Delhi or Mumbai. It is applicable to Amravati. It's applicable to the smallest village in any part of the country. Every citizen has the right to actually exercise this ruling or this judgment, looking at the patient's own rights. So thank you very much.
Dr. Pandit, one important question, I think.
Bolo.
There very quickly. Someone wrote, Dr. Shashi, that do we need to take our consent even after brain death to withdraw?
Okay. I will answer that question now.
Yes, that's why I asked you.
I
always clarify that.
Very clear about it, that when you are dead and you are basically declared brain dead, or you are dead by the cardiac criteria, organ donation requires consent. So whatever way it is, organ donation requires consent. Withdrawal of ventilator or inotropes doesn't require consent legally because you're dead. Now, no human being on this planet will just go and pull the tubes out. Often this context is taken as a happening at a one point. No, if I am talking about brain dead to a family, I have developed a good rapport with them. Number of hours of meetings have gone discussing about it with them. Process of organ donation has been explained to them, and there is that rapport which is already developed. If the rapport is developed, I would talk about withdrawal in the same way I talked about organ donation or brain death. And most families will give an assent. I like to use this word assent. They may not be a consent, but they would all agree. They would all agree to what we discussed and would say, that's fine, withdraw the ventilator and go ahead and hand over the body to us. Now, if you want to protect yourself legally, you could just document that in your notes and say that this has been discussed with the family. All their questions have been answered. You could actually go ahead and document the questions which they asked as well, that these were the questions asked, these were the answers given, and we are withdrawing the ventilator because the patient has been declared dead by brain death criteria, brainstem death criteria at so and so time on so and so date. and organ donation is not consented. That's about it. You really don't need a counter signature of the patient's family, because the entire process is documented already on the Form 10, which is a Government of India's TOHA Act form. So you really don't need that. So I think organ donation is completely different. We unnecessarily fear about organ donation. If you have done it in the right way, and if the patient is declared dead, as Dhwani said, and as I like to say always, if you're dead enough to donate, you're dead enough to be withdrawing care. Okay. So with that, Tushar, at the end you are asking a question. I
No,
can't
sir.
ask you no to
I
it.
have asked the question in the chat box, but
In the chat box, actually, Tushar put hai.
yeah. So now in the era of Mediclaim, I just wanted to. Most of the people want to continue aggressive care for long period of time, and as an intensivist, when we talk about the palliative care, the family understand that we are trying to just nudge the. We're trying to give a shoulder to them. That is causing little disconnect between patient and the doctor treating. So recent time I've seen couple of times that we are being taken into an account about that we are not treating well after discussion of palliation when they try to be aggressive on the treatment. Should there be a concept of treating versus non-treating intensivist taking part in palliative discussion? And should the treating intensivist should be always part of a palliative discussion? That's the only question I have.
Okay, this is very much the last question. Then Arindam, you are going to take over and close the session. Mani sir or anybody can answer it. Mani sir, you want to answer that?
Okay, I'll answer briefly, then Mahesh can take over. You see, I think intensive care physician must have palliative care skills. Okay, this competency is extremely important. There are, I think, 7 or 8 these out of 45 competencies that the European Society of Critical Care has identified. So it is a part of our job. We do general palliative care. We don't do specialist palliative care. But you are palliating when you're giving analgo sedation. You're palliating when you're touching the patient. You're palliating when you're assessing for delirium. You're palliating when we talk to the family. No, look, we can't compartmentalize this. We've got to integrate it. That's what I believe. And Mahesh, your take.
Mahesh.
Yes, thank you. I'll also make it quick. Yes, we many times we are concerned about the image issue that happens, but these are transient in the sense. I think it's about establishing understanding. We'll face the same challenges, like we are looked upon as harbingers of death when we are coming to the table, but that's not the point. So we are talking about. We say the same thing. Sometimes we tell the families that look, they are already receiving palliative care from the primary team. They are taking care of pain. They equate palliative care with abandonment. So this has to be made clear. Nobody is going to abandon the person. We are continuing to take care, and we're giving you a choice to respect the wishes of this person because the person cannot speak anymore. So you have to tell us what would be good for this person, pain relief, so and so, so and so. But you give them those choices, and then whether they continue to escalate or de-escalate, many times they think we are cornering them into a situation, and that has to be very clear. So many times we have to come and tell them, look, we are not here to tell you to do this. We are here to ask you what has to be done, and we'll take a decision. We'll cogitate. This is the so.
Arindam, over to you, and you can
Yes.
close the session and talk about the next session as well, so that
So
we can
thank
close.
you, Dr. Pandit sir, and also all the panelists, Dr. Mani, Dr. Menon, Dr. Sayi, Dr. Shashank, and Dhwani madam. And in fact, some of our lady doctors took a picture of Dhwani madam keeping the baby in the lap and participating in the conference itself. So they said, "Go, woman, go!" A big A. So thank you for being with us, with despite all the obstacles and not obstacles, but despite the
Sometimes they are obstacles. It's fine.
and I know I can understand that part. The only we would come back next month. We have not yet decided, but going by the response that we got, the interest, the active participation of the people about this topic. So somewhere I think Dr. Pandit will decide. We will come up with more relevant and topics which are indeed needed to help in our practice. and we try to involve multidisciplinary as well as people from other aspects of the care, maybe medical, even non-medical people, to have a better perspective of our practice itself. Only two things I think Manish sir will guide us in future along with Dr. Pandit, that maybe we can form a ULC matrix which can be easily accepted by most of the hospitals, and maybe we can push for, Dhwani madam can guide us to for the state level. I think Dr. Pandit can start it in the Maharashtra level, so that we can have a board or a panel of experts who can be quickly roped in for the secondary committee. So these are the two requests from most of us that we have understood. And
Yeah.
see you next month. And Dhwani ji, we will involve you in the future.
Sure. I just wanted to tell everybody to, watch out for this. I mean, there's hopefully going to be a Supreme Court hearing on the 18th in the matter of Harish Rana, who is a patient in the permanent vegetative state, from whom the parents have requested withdrawal of his PEG tube. So their ISCCM has actually filed an intervention application, where we again want to bring to the attention of the court that its guidelines are not being followed, are not being implemented, and they need to do something about it. So basically, yeah, watch this space, watch for those developments, and hopefully we will see some progress and see the court again coming down on or at least directing state governments to take steps to implement its procedure. So I will keep you updated about that.
Maybe
Thank
in
you.
a couple of months' time we can discuss about this in again
Sure.
more detail, and hopefully by that time, if at least Maharashtra, I think
Yeah.
Odisha is also having some movement at their ground level where they're going to appoint some.
The UP government from the health secretary, intimations have gone to all the districts.
Yes. So we can actually talk about it. If we have a case which happens, we can actually discuss about that. We could get that doctor in to talk about how they went ahead with this.
Thank you and good night to all, and we will meet you next month.
Thank you very much
Thank
from
you.
the bottom of my heart.
Okay,
Thank you
see
very
you
much
all,
for giving your
folks.
time, precious
Okay.
time on a weekday between 8 to 9. That's your home time. We realize that, Dhwani ji, we took you away from your kid for an hour and a half. So sorry for that. Thank you very much. Bye bye.
Thank you. Thanks a lot.
Good night. Thank you.
Bye, everyone.